be better, and look forward to hearing her thoughts.
Well,
Claudine.
Thank you so much, Dr. Bacon. So we are really honored today and very excited to have Dr. McCulloh Nair from Westchester University in Pennsylvania to discuss advancing rural healthcare. But before I introduce our speaker, let me go over some housekeeping issues. We continue providing CME credits for our ID series presentations. We will distribute the information via email to those who registered for today's event. And if you did not register prior to today's talk, you can still obtain the CME code information from Deborah Rees, and her email address will be posted in the chat box. Our next ID series will be on June. Let me get, in fact,
It'll be
on June 24th, sorry.
Correct.
So the next study series is on June 24th, and we'll have a speaker from University of Delaware, Dr. Dan Harris, who will talk about medication management of herpes zoster in US nursing home residents. So please, make sure that it is on your calendars. That will be on June 24th at noon. So again, I'm really delighted to introduce Dr. McCulloh Nair. Dr. McCulloh Nair is currently Associate Professor of Nursing at Westchester University and Director of the RN BSN program in the Department of Nursing at Westchester. She's also a nurse scientist at ChristianaCare and a visiting scholar and honorary fellow at University of Dundee in Scotland. She obtained her PhD in nursing from the Medical School, University of South Carolina, and is also board certified as an advanced public health nurse, and also completed a bioethics fellowship at Medical University of South Carolina. She's a very active teacher and mentor and has received many honors. For example, was recognized both in 2024 and 2025 as a top nurse under the nursing research category in Delaware Today's Top Nurses edition. In 2018 and 2019, she was on the advisory board. She was an advisory board member of the Delaware Behavioral Health Consortium to provide Governor Carney strategic directions for the opioid crisis programs. She also has many peer-reviewed publications and presents frequently at national, state, and local meetings. So, Dr. McCulloh Nair, we are really honored and excited to hear your presentation.
Great. Thank you all so much for having me here. It's a privilege for me to be here to speak to you about this topic that is very near and dear to my heart. So I will go ahead and get us started. If I can advance my slide. Hold on. Oh, there they go. Okay. So to start off, why Scotland? So really briefly, a few years ago, I had the opportunity to spend time at the University of Dundee. While I was there, I was absolutely intrigued learning about their rural healthcare system delivery. So much so that I ended up going back. And as Claudine had said, that I received an honorary fellowship through them to come back and study the rural healthcare that they do deliver throughout the remote, rural, and island areas across Scotland. So they do have several models that they use, and some of that we're going to get into today, but one in particular really, really seemed to fit very well with the U.S. healthcare. All right, so just before we even get into that, so very briefly, in case people aren't aware about our current state of U.S. rural healthcare. So as a nurse scientist, I also have a specialization in vulnerable populations, and somebody who has lived in rural healthcare areas for a lot of my life. Again, near and dear to my heart, and I understand the barriers that we often face. Many of our rural residents experience poor health outcomes that comes along with increased risk of death. It's attributed to increased risks of chronic disease, of substance use, of reduced access to healthcare facilities and services. But the good news is that the U.S. does prioritize this. We do have funding towards this that supports delivery efforts aimed at community programs. Some of those grant programs we'll talk about a little bit later today, like HRSA. But despite all of this and these efforts, we still have a lot of challenges to face in our rural areas. Sometimes this is due to geographical and transportation barriers. Sometimes it's inability to recruit and retain staff. Hospital closures, clinic closures, lack of ambulance services, also poverty. Is another issue that we encounter a lot. People can't pay for the services. We have issues with digital connectivity in a lot of our rural areas. And then there's a lot of other social determinants of health that we'll save for a little bit later to kind of get into. So here, so U.S. rural healthcare. When we look at the overview of this, so we have delivery systems, absolutely. We have plenty that are based on like numerous models that you can find in the literature, frameworks, various approaches that include things like our hub and spoke models, our community health workers, medical homes. We have our federal medical homes, telehealth programs, which we really saw expand a lot during COVID-19. Rural clinics, you name it. So we have plenty here in the U.S. When we examine the current state of the U.S. rural healthcare system, it's apparent that what we do have in existence is not necessarily meeting the needs of all of our patients and rural residents. So there's often a lot of discussion around centers of new centers of technology and new advances that we commonly use. But we do have problems with our digital technology approaches, especially in remote rural areas. We don't have that connectivity yet. This was something that was very different for me to witness in Scotland, and I'll talk a little bit more about that in the upcoming slides. One thing that we really do need to note too about technology in particular is that in urban settings, yeah, we do. We tend to have a lot of more resources. The funding's more abundant for this. We can adapt quickly, adopt quickly. In rural areas, that's not always the case. There's a lot of different payment systems that you have to encounter in rural areas and take into account. Also, lower volumes of patients. Rural providers might be compensated differently. They use different methods, non-traditional systems, and fee schedules. So it can make it harder for them to actually adopt and implement new technology and do it quickly. So we really need to start gaining a better understanding of how our rural settings are affected by these new models and frameworks, and in particular, these new technologies. When we look at Scotland, for those of you who are not very familiar with Scotland, just briefly on this, so they have plenty of models that are very similar to the U.S. So you see these here on the slide, the delivery mechanisms. Looks familiar, right? Very similar to what we see in the U.S. So I just want to shift gears a little bit and kind of talk about Scotland in general and its geography. For those of you who are not familiar with this, what they call is the Central Belt. It ranges from Glasgow to Edinburgh, which you can see, hopefully you can see my pointer. There we go. So this area right here is what they call the Central Belt. This area holds the majority of their population. And you can see down here on the borders, they also have rural areas, but up here, so all the islands and the highlands, these remote areas, it is a vast, vast area of remote, mountainous, coastal regions with people living there. But what astonished me the first time going there was the ability to provide care to everybody, which just shocked me. People are not left out. And that's sort of what I wanted to go back and really explore and get a better understanding for how they're doing this and how they're doing it so well. So obviously they have the National Health Service, or the NHS. They are responsible for delivering services throughout these regions. There's various mechanisms that they use to do that. And they also have differing health boards too, and those health boards are responsible for these very specific regions. Some of those services include your ambulance and emergency care, your primary care, education and staff development, retention efforts, that all falls under the NHS. Also the development and sustainability of community engagement programs. So one of the areas of services that I found that was very interesting was their use of incentives that are provided to healthcare providers. It includes education, some bursaries. So when we talk about educational costs, and this is different too than other areas of the UK, like in Wales or in England, they don't always, and actually that's in the process of changing right now in England, where they will be paying more for their education. In Scotland, for healthcare personnel, particularly for nursing, like one of the big things that I was shocked with is they don't pay for schooling. And not only do they not pay for their schooling, they're also paid to go to school. So they, on average, earn £37,000 a year, which is enough to cover their expenses while they're going to school. They also have housing provided to them if they need it. And this is even their healthcare team too. So that was astonishing to me to see that physicians, anybody within the healthcare, industry that is providing care in these regions, they do have access to free housing if they need it. They also have some really interesting programs too, that are newer for their GPs, like the fly in, fly out, so they can get in quickly and get back out to see patients. They don't have to stay and live in these areas. And then their use of video conferencing, that just shocked me, to be in some of these very remote areas. Like one of the islands that I had been to were the Orkneys, which are very remote, and then even more so remote over here is the Outer Hebrides. And to be able to get on the internet and have no issues just blew me away. Knowing that I live in Pennsylvania in Chester County, and I'm in and out of Delaware. I also have a home in Sussex County, and knowing I can't get cable in my house some days and internet to work, that somewhere like this on these remote islands, that it's not an issue. So just some opportunities for us to really think about. So on this slide, this is just going to show you kind of a visual, if you will, of some of the different types of remote, rural, and island facilities that are used to deliver healthcare in these regions. They have FORFAR, which you see here, the surgery. This is in the Glens and the mountainous regions. It's right at the base of the Cairngorm Mountains. Very, not as remote, but not always easy to get to, particularly during weather, a lot of rain, a lot of fog, snow, ice. It's not unusual to have farmers bring patients in their tractors down to meet healthcare providers. So these areas can be pretty tough to access at times, especially at night. But they have primary care facilities in all of the villages throughout these areas. A lot of these surgeries are transformed homes that were not being used. And they have just enough equipment and personnel that are regularly scheduled that they can manage the day-to-day healthcare concerns that that village population, even surrounding areas, have. One other thing I wanted to point out too, like for example, in this surgery for FORFAR, there was another one that was even more remote in this little farming village that I went to and toured. And they have shower facilities, a kitchen, a living room, bed. So the healthcare providers that are cycling in and out, or if they want to go and they want to stay for the day or are scheduled to stay for 24, 48 hours, they have all those facilities on site for them. Another one over here you see is Portree Community Hospital. This is located on the island of Skye. This actually, speaking to their healthcare providers, I interviewed a lot of people while I was here in Scotland, and just to get a better concept, an idea of what is your day-to-day experience as a healthcare provider. And the one in particular I spoke to on Skye was advanced practice nurse practitioner, who had worked in the mainland for years and years and then decided to retire. Along with a lot of other people who are looking to retire on the island of Skye into these very beautiful scenic coastal regions. And then you also have the mountains. But I found this one really interesting. It's a community hospital. They do have everything they need to sustain life, But what they do is they can either stabilize you and send you out, or you're going to stay and you'll go through whatever care that you need. The thing that I found really interesting with Portree that reminded me so much of Delaware is the summer population. It expands by 100,000 people, and that's the hospital. It is very, very small. And I asked her, what do you do? And she said, we just stabilize and send out. And sometimes people are waiting. It's just the nature of what they're dealing with, but they do also recruit a lot of extra healthcare personnel during those summer months to come in and to help out. A lot of times they're sending patients out by aircraft, by ferries, by ambulance, whatever they need to do. Most of the time they're going to Inverness, which is the next nearest trauma center that they can send your more acute injuries to. They also have a lot of community programs there as well, where they have something called at home. It is very, very similar to some of our community programs like Hospital at Home, where they just treat the patient at home. They have a lot of telehealth kind of connectivity that they can even get even in this remote rural area. Some of these areas are agricultural on the Isle of Skye. You've ever heard of the term crofts? You'll have croft villages. They're farming villages. Some of them are very, very hard to get to, and you have to get over the mountains to get to them. But they do have staff that are typically on a schedule where they're going and they're seeing all these patients on the regular. So very, very interesting how that they go about delivering care in some of these areas. And even with Portree, they have diagnostics there. They have an MRI, they have a CT scan, they've got all your labs, anything that you need. Another one is Ragmore Hospital that you see down here on your bottom left. This is the hospital in Inverness that handles more of those trauma type events that occur. And if you can kind of see in the background here, there are some little white buildings, right? This is housing. This is all healthcare housing. Pretty nice. Some of these are 1-2 bedroom condominium type or apartment type facilities where they have everything they need. And this is housing that's provided to the healthcare providers. So a little bit different than what we do over here. And then the other one too I wanted to touch on is this North Harris medical practice. That was the Outer Hebrides that I had pointed out before. Even in those very remote areas on the islands, they still have these types of facilities set up where they've got your basic needs are met. In particular, some of the ones in the southernmost regions of the Outer Hebrides, they'll send staff, and it might be a 48, 72-hour assignment where they have a regular schedule of like 4 or 5 nurse practitioners. You might have GPs going in and out of there where they're going and they're staying, and they might be there for 2-3 days at a time, and they have all their food and everything that they need provided to them, and then they can cycle back out and go back to their home. So a lot of interesting things there and how they manage their healthcare staff. So some of the partnerships that they use, they really rely heavily on their partnerships to inform their practice, also to improve their services across the country. Teamwork overall is so highly valued over there. They actually changed my perspective. Not that I had a bad one on interdisciplinary collaborations going into this, but it really changed my mind, more so in the academic area of how interdisciplinary work is delivered. For example, their nursing program transitioned 2 years ago into an interdisciplinary faculty. So you actually have pharmacists who are now teaching pharmacology, psychiatrists who are teaching psychology. It's just very different, and it just provided such a rich experience, whether you were in the classroom or if you were in a clinical setting. One profession is not valued over another one, and there's just this true collaboration among all colleagues. Turas is a system that they are currently building. They want it to become this international repository where knowledge can be shared among colleagues. It is now like the place to go to for NHS Education Scotland, which they call NES. This is something where they collaborate heavily across the country with the university partners. One thing I thought was really interesting where universities were working together. They were not competing against different types of funding and different types of initiatives. Instead, they were all working together to try to systematically, really approach and to try and work out finding solutions to some of their bigger problems. And the other thing too is that community is really at the heart of Scottish culture. There are many, many, many community organizations that work in tandem with your NHS healthcare, with a lot of the other, there are some private insurers, private hospitals over there as well, that they all work together. Just, that's the common goal, is to improve services. So on to the Scottish model. So this is what I was introduced to primarily. So the National Center for Remote and Rural Health and Care was established in 2022. The funding, the Scottish Parliament it was 3.3 billion pounds, I'll make sure I didn't say dollars, pounds, that they invested into developing this program and this center. So what they're doing, they're currently addressing remote and rural healthcare inequalities. They're also working to try and improve primary care services in these remote, rural, and island settings. They're also working to enhance their workforce and to deliver and sustain their community-based services. So the center serves as a rural healthcare model that uses a systematic approach to plan and deliver care. There's 4 pillars that you see up here on the screen, which focus on key outcome areas such as research and evaluation, your education and training, recruitment, retention, leadership and good practice. And you see at the heart of this, again, it's communities. So now we're going to take a look at those pillars. So when we're thinking about strategies for education, recruitment, and retention. NES, or your national, what we talked about before, the National Education for Scotland, they've spent the past 15 years leading, developing, and delivering education to rural teams. The Rural Advanced Practice Master's Program is something that is delivered through the University of the Highlands and the Islands. Classes can be on site, but primarily they are remote. This is really geared towards your nurse practitioners, your GPs, your ambulance personnel. So it's an interdisciplinary degree. And then they also have their long-term partnerships with Norway in particular. They actually thought it was funny that I was there to look at their model, because it's like, oh, you might want to look at Norway too, because they do partner heavily with them, as well as Australia. Obviously, they have very similar terrain and some of the same issues with rurality. They also have something that is called the Making It Work framework, which you see up here. I invite you to please take a look at their website if you're interested in it. It's simply the Making It Work website. But this came from a partnership of northern countries, and this was Norway, Sweden, Canada, Iceland, and Scotland that worked on this. I believe it took 9 years to come up with, or 7 years. They used participatory action research to explore and identify challenges with recruitment and retention of health professionals, specifically in remote areas. The framework was developed. It has these 9 key areas that you see up here with 3 specific tasks. So again, I definitely invite you to take a look a little bit more at that if you want. That is one of the outcomes that I did realize and kind of knew going into this, that you can't just pick somebody up who's never lived or worked in a rural area and plunk them down and expect them to thrive. That doesn't work. So that's a lot of what they're addressing through their educational initiatives. And you can also see here on this screen, Dr. Pam Nichols is the Associate Director of Medicine at the center. And I met with her in Inverness. She's an incredible physician, and some of the main areas that she really focuses on in terms of teaching are listed up here on the screen and can also be found on their website. And then you can see here too, Sternaway in the Outer Hebrides. That is where I went. I visited the University of Highlands and Islands while I was there, and met with a lot of the nursing faculty. And I got to meet with their nurses who were studying at the bachelor's level. Gave me a new perspective on what people do when you're in these rural areas who are trying to seek education. And one of the best examples I got was a nursing student who lives down here in the Southern Hebrides. 4 hours. She gets up at 4 a.m. to get to her 8 a.m. class all the way up here in Sternaway. And she drives across 3 islands and takes 2 ferries. So next time any of my students complain, that is the story they will receive from now on. But it works. They have, they really work very, very hard over there to make sure that those who are living in these areas that want to work in healthcare are highly supported through funding, through housing, and essentially whatever they need to get through school. And then a lot of them, surprisingly, are retained, and they do stay in these areas and work. And those who do leave and go to the mainland and do work, they do tend to come back by the time they're getting ready to have families. So they really work hard to build a network from within. Okay, and then strategies for research and evaluation. So this specific pillar of the National Center really aims to increase capacity and opportunity for research and evaluation, really looking at primary care and community service workforce within Scotland. And when I met with Dr. Nichols, it was music to my ears, because she said, Julie, when you see one community, you've seen one community. I was like, right, exactly. And she said, always the first step is community-based participatory research. I thought, I found my people. That was always my focus area as a doctoral student and even after schooling. So it made absolute sense to me that you would go to your various communities to really identify what are those barriers, what are your gaps, what are your community solutions, looking at all the social determinants of health, looking at workforce issues, which, as you see on the screen, that's all of their key focus areas. And then also they use the systems level approach when they're looking at issues. They look at Scotland as a whole, and then they determine where they're going to allocate their resources, such as transportation, their housing initiatives, any kind of education that they're providing, any skills, anything in terms of resources. And they also establish a virtual network of national stakeholders that are interested in research and evaluation projects that specifically are focused on our rural areas. Their tasks are to facilitate new projects, platforms, and collaborations, build research and evaluation skills, provide resources to support research activities, looking at increasing development and finding more funding mechanisms. They really want to collaborate internationally. That's something that I'm hoping to continue to do with them as I start collecting more data in the US. It's something that they would love to be looking at and having it, again, going back to that center and having an international established data dashboard if possible. So I'm really looking forward to working with them in the future. Some of the strategies for leadership and good practice, that fourth pillar. So one of the things they use their primary care practice models primarily when they think about leadership and good practice. They're working to develop a course that's going to support the sustainability of your primary care services. It's really geared towards GPs, advanced practice nurses, pharmacists. It's almost like, if you will, like this course, they're hoping it to kind of become the train the trainer. So they're going to teach them about leadership skills within rural areas, sharing all of those good practices and leadership, evidence-based practices, if you will, from rural areas. One of the other programs that they just started, which was really interesting, was their Scottish ambulance service. And they have them now going to this leadership and good practice initiative as well, where they're using their ambulance service to deliver primary care, which is very interesting. And so far it has been going incredibly well over there. Very much like what you see here in the United States too, where, our ambulance personnel do tend to know people. They're at their homes quite frequently, and rather than taking them to a very, very, very busy emergency room, a lot of times they're able to just treat them in the home with by consulting with the GP at the healthcare facility. So it's saving a lot of trips to the emergency room so far. So very promising program. All right, so I'm going to kind of switch gears here now and start talking about the translational research opportunities in Delaware to advance rural healthcare delivery. Just a very brief overview of Delaware. So rural Delawareans do experience poor health outcomes that are similar to rural regions and other rural regions of the U.S. Same kind of contributing factors, but specifically when you look at Delaware, you're looking at substance use, chronic conditions, infant mortality, lack of insurance, and poverty. Delaware's population has also seen an increase by 6.3% since 2020. That further taxes the limited resources of the 17.9% of Delawareans that are still residing in these rural areas. And when we compare Scotland and Sussex and Kent counties, which are considered rural regions, they do share quite a few similarities between coastal regions. Your social determinants of health can be very similar. Tourism is very similar. The limited resources. The 4 pillars of the Scottish model could easily be replicated in Delaware and serve as a guide for rural healthcare experts to model their research and their interventions. For example, in Scotland, they surprisingly, they do have the lowest life expectancy of any country in Western Europe. They're not sure why. And it's particularly males. 60.9 years is the average. So, and females are sitting at about 61 years on average. So 24 years less than some of your high income areas throughout the UK and other parts of Western Europe. Some of the things that that are hypothesized and to some extent now are cardiology issues, lifestyle, smoking. They do have an alcoholic alcoholic epidemic over there. They do have other types of substance use disorders. Access to care, though, is different, where people do have more access to care and quality care. They also have housing that can be provided to them. So, and then again, the tourism, I can't remember if I did say this or not, but over in Skye, I think I did earlier about like they expand by 100,000 people. So we see this very easily in Sussex County, especially during the summer months, and the kind of burden that places on healthcare services. Slide over. So this slide, this is really looking at what are our existing organizations and programs that we already have in place that could be used. So identifying them and inviting these organizations to become community partners is really essential when you're trying to close the healthcare gap in some of these rural communities. Again, the 4 pillars that centered on, they specifically center on communities. And that's something that they were trying to teach me over there is really look at what are your resources already in those communities. What can you build on? What can you introduce? So this slide is really sort of showcasing this, where you can see at Christiana, we have our hospital at home. We have a lot of telehealth services. We also have the Newcastle County EMS, which is also piloting a primary care program, which is similar to the one that they're piloting in Scotland, and so far seems to be successful in both countries. And then the Angel Flight East is an example of free access to air travel for healthcare needs. It's also very similar again in Scotland when they're using aircraft. It was one of the things that I was introduced to initially, the first visit I went to Dundee on, where I met with a nurse who her regular schedule is getting on aircraft and flying to the islands, helping to deliver babies. And if mom and baby need to come back to the mainland, she's flying them back. They might be getting labs, diagnostics, some treatment for a few hours, and then flies them back home at the end of the day to the island. So very different type of nursing than what we tend to see here in the US. So Angel Flight East is an example, not to that extent, but it is an example of an organization that if you did need free air travel, you could access that. And then Sussex County Health Coalition offers a community-based collaborative effort to improve the health of children, youth, and families. We also have the Delaware Rural Health Initiative. That's another collaborative effort between reps from the Division of Public Health and also the 3 hospital systems, Nanticoke, Bay Health, and your BB. So they work together really in this shared region to try and enhance and deliver care. Lored Health Center is a medical home providing healthcare services to a rural community. You also have your physician shortage area programs I have up here on the screen too, which is really important. That's something that Jefferson School of Medicine offers. For those that are interested in becoming a physician, they can go through this program, which provides additional support. It has been very successful and been around, I believe, since 1979. Similar to some of those educational programs that I saw in the UK. And then the leadership, good practice, education and training, all of those pieces, those pillars all kind of fall into all these different types of community partners. Excuse me. So then first step is really identifying what is rural, right? So making sure you understand what, are you in a rural area, and how is it defined? There are 3 federal offices: the United States Census Bureau, the Office of Management and Budget, and the United States Department of Agriculture and Economic Research Services. They define what is rural. Essentially, like your census defines it as urban areas as having at least 5,000 people or 2,000 housing units, whereas the OMB, essentially, it's less than 50,000 residents. HRSA also identifies the use of their rural healthcare grant eligibility analyzer. I'm gonna grab my water, excuse me. You can see here on the screen on the bottom left here, I just plugged in Sussex County, and you can see that immediately came up with, yes, this area is allocated as a rural region, and it is eligible for rural healthcare grants. They also offer, HRSA also offers several maps that can be used to determine various data points, such as where are these rural health areas, what's the number of facilities, how many providers who are offering rural health. So really, really great resources that you can use. And I left a link here for the tools that you can access for HRSA. The Rural Health Information Hub. It also provides a link to funding opportunities for states. And that's over here on this side of the screen. Delaware funding and opportunities. You can see I had pulled that up as well. And what are the shortage areas? So you can see a lot of the information and organizations listed here, as well as the link. Essentially, this is opportunities by state that you can plug in and look at what is available in terms of how to access healthcare, shortage designation info, and data. For the HRSA opportunities, so the Federal Office of Rural Health Policy administers grant programs that are designed to really build out our healthcare capability at both the local and the state level. Their grants are available to individuals and research centers. They provide funds to 50 states of rural health to support improved services such as care delivery, emergency medicine, workforce development. They provide technical assistance to people in rural hospitals. They also provide grants for community-based programs. And then when I looked at the Rural Health Development Program, unfortunately, Delaware is eligible, but it is not current or has not previously received funding. So definitely an opportunity here because it does qualify. When we look at other funding mechanisms in Delaware, obviously we have the ACCEL network, your Delaware CTR, and on the screen I have all of the different ACCEL funding opportunities listed here. We have community engaged pilot grants available, so I highly recommend taking a look at that to see if that might be something that that you as an individual or maybe a community partnership or even an academic setting might want to try and take advantage of that type of funding to really kind of start looking at what are some of these areas that we should be looking at in Delaware. The Delaware Embry is another funding mechanism that can be used. They do have funding opportunities for new research directions. So your pilot programs are typically either $40,000, development of research programs. They have the two-step, which is an $80,000 program. And again, the website is here for anybody to take a look at if you're interested in that as well. And then finally, really what the takeaway on this, or what are the primary opportunities, at least from my perspective, that I found after spending time in Scotland and also looking at the same time and trying to look at what are the gaps here, particularly in Delaware. when you look at that, obviously CBPR, what I talked about earlier, when we think about having that community-based participatory research in our various communities and these rural areas, it's critical to get a better understanding, gain knowledge from that community, having them identify what are your priorities, what are those gaps, what could those solutions look like, taking that information and then using that to build programs to address those specific needs and those gaps, even forming policies around those. Right, that's all something that can also then be monitored. You can use outcomes research over time, and once those programs are implemented and policies are implemented, that's where something we could use outcomes research to really tell us how effective is it over time. And then also looking at designing and delivering a rural healthcare certificate or degree. That's something that I'm engaged in right now in the state of Pennsylvania, where we're going to be building a rural healthcare certificate specifically to Appalachian regions in Pennsylvania, but that's something that could be replicated in Delaware too, where you're looking at more of those agricultural and coastal regions too. What do rural healthcare providers really need to know in terms of skill set to really thrive in these communities and to keep them there? We want to see them retained and not somebody that just moves there in a year or two, says, nope, I can't stay here, it's not what I thought, and they leave. And then lastly, my other thought on this is maybe there's opportunity to develop the Delaware Rural Health Research Center, very similar to what they're using over in Scotland. So there's a lot of opportunities around research. I think we're at that point where we really need to start looking closely at some of these regions. I spent a lot of time trying to pull data on rural health in these regions, specifically in Sussex County and to some extent in Kent. It's not easy to find, which leads me to, which I would hope somebody here today might be able to tell me where I might be able to find some more of this information. But I would love to envision or see a data dashboard at some point in time around Delaware and some of the rural healthcare needs. So with that said, I'm going to stop. And I just want to spend some time answering any questions that you might have, or to give you some more information about the experience I had in Scotland. So I'm going to go ahead and stop sharing. Okay. And if anybody has questions, please let me know.
Thank you so much, Julie, for a great presentation. Anybody with questions, please either raise your hand or unmute yourself. Well, I have a couple of questions to start with, and I'm sure we have, a few more coming up. In fact, I have two questions. One related to the care, and one more related to research. For the care, when you said that physicians fly out in and out, nurses, physicians, I mean, it seems to me that it could be a barrier to continuity of care, because if they are a team, one team every 48 hours, it's not really a primary care physician who take care of their patients. How do they manage that?
That's a good question, Claudine. So the one that specifically I was talking about, when we look at the island care, the one model I saw, the nurses, there's 4 nurses, sometimes a 5th, from the islands, and everybody knows them. And they have been doing this for years, where they will go and they will stay in these different clinics to see different patients in different areas of the island. So it's this constant scheduled rotation. And it is the same providers going. They don't have as many GPs over there, though. So a lot of healthcare is really run by advanced practice nurses. I didn't understand until I spent time with their advanced practice district nurses. They're actually on a level a little higher than our advanced practice or our nurse practitioners. They have their own patient loads. The one I was with had 180 patients that she cares for regularly on her, and that's her primary caseload. So that really filled a gap where we have here, because they do have a lot of problems with primary care. They just don't have enough practicing primary care physicians anymore in the country. It's just very similar to us. So but they do, in a lot of these rural areas, they have what you'll call homegrown practitioners. So a lot of the physicians that grew up in those areas, they're there and they're still working and they're very much part of the community and everybody knows who they are. So that is a little bit different sometimes than what we see here.
I see. I saw
Mm.
Dr. Dufus has his hands up.
Mhm.
Wayne, do you want to unmute?
Yes. Can you hear me?
Yes.
Mhm.
Can you comment, or do they have mobile services, and how do they use them in Scotland? That's my first question.
They do. So they absolutely do. Even in some of these little clinic areas, they use a lot of the teleconferencing. So they can send somebody out, might be a nurse, could be a community health worker, could even be a physician that goes out to a home, and they might have an iPad, but they can connect remotely when they need to different centers so that people can see the patient in their home. And then they do also have, actually, this is a really great question. They have mobile units that will go and see patients. They also have a mobile skills lab that was pretty phenomenal with a simulator in it. Couldn't believe. So even when they have new technologies that are coming out and they need to train healthcare staff on how to use them, they're using that too. So they use this mobile educational unit as well.
Great. The
Yeah.
second thing I want to ask you, I don't know if you have an answer, but could you comment in an environment in Scotland where they have national health insurance, right, the NHS,
Yes.
versus in the US where you have a lot of
Yep.
uninsured or underinsured? What challenges and how would you amend or adjust some of the great ideas that you just put forth?
So sadly, I got quite the education on NHS, and it is failing. It is expected not to survive, which is really sad. And they're just taxed. They do not have enough providers anymore at all, and the resources are just drained. And it's pretty scary when you listen to the stories by people. And most people carry their own private insurance now that can afford it. They don't rely just on NHS anymore. They can't. They have to go and see providers and pay out of pocket, or they have their provider network that's private now. They gave us examples of even having you might be thinking you're having a heart attack and you're calling and trying to get in to see somebody. There could be a wait, which is very scary. And that's not something that they have previously ever experienced until the past couple of years. And you might call at 8 o'clock in the morning to get an appointment, and you're lucky if you get one. And if you're not, they tell you, sorry, we're full for the day. You'll have to call back the next day, and you start all over again. You're not even on a wait list. The one person I talked to, they are on an 18-month wait list to get a new knee. So they are having a lot of problems with NHS, and that's something that they're working to tackle right now. And how this is going to look very differently. Obviously, they're also looking at the US in terms of how our insurance system is, because it's unfortunately where they're starting to move.
Dr. Bacon?
Thank you.
Well, thank you. And your last slide discussing the potential for research activities and networking, certainly timely, particularly, I'm sure everyone on this call is aware of the PBRN being developed by Lee Pachter and Barb Devich, looking at practice-based research network. We've been fortunate to have a large number of practices in Lower Delaware that have been committed to this process. And that's a really big deal, because I think that that extends the network into the populations you're talking about, along with an immigrant population in Lower Delaware as well. So it's I mean, that's where the focus is right now, and that's the CTR is moving in that direction. So really timely discussion, but I really appreciate that. Thank you.
Yeah, and I was so thrilled to learn about that from Lee, because I sort of, when I was leaving, I'm like, oh boy, we really need this type of network. And then to find out we have it, it's just amazing. Such a great opportunity for us. Yeah.
So I have another question related to research. So you mentioned that they were doing research also in Scotland, and I was wondering what was the infrastructure there, in these rural area for evaluating and doing research. Do they have people coming from the university, or how does it work?
So that's a really good question, Claudine. So they have a lot of different sites for these universities. So even like University of Highlands and Islands, they have multiple campuses scattered throughout the Highlands and the Islands. And they have a lot of faculty at each university, and they're all working collaboratively. You also do have people who will come in from the National Center, and they might stay in some of these areas while they're working with communities and doing community-based participatory research. So there is a lot of mobility of people moving around and coming in and out of communities. But primarily they do have academics. And they do have clinicians that are partnered and working in these areas to collect that kind of data. And they're really building a pretty great dashboard at the center right now that we're hoping in about a year or so, a lot more of that'll be public. They've got about 2 years worth of data that they've been compiling, and they hope to start sharing everything internationally.
So do they have people who are embedded in the practices? I mean, I guess it's kind of what, we are trying to, kind of doing with the PBRN. Is it the same type of programs there?
Very similar. Yep. Very, very similar.
See.
Yeah, and you have a lot of the
Interesting.
practices are definitely engaged in this type of research, and a lot of the community organizations are engaged in the research as well. And it is interesting when you see the effects of CBPR over there, because there are some services that are offered in some communities that you don't find in others. There was one that I visited with, and I spoke to the person. It's really more like a social care community-based organization, but it was founded based on that community's identified needs and gaps in services and what specifically they needed. And some of it was supported through NHS, and a lot of it was supported through community grants and funds. So it is interesting to see the effects of that CBPR and how it's rolled out, and how not every community is the same.
Mm-hmm. Any other questions? Well, I have another question while we are waiting. So you mentioned that NHS was not working well at this point,
No,
but
unfortunately.
all the infrastructure that you were talking about, these hospitals and all the infrastructure, then who pay for that?
Scottish Parliament. It's all coming from government funds.
It's not NHS.
Right now, NHS does have that. They have that comes out of the Scottish government's funding, because it's different depending on where you are, who's funding it in the UK. Like you have NHS England, and that is their own pot of money, whereas NHS Scotland has their own pot of money, and they fund all of those programs. So it's just going to be a shift on how they're funding things, how they're allocating services, and there's going to have to be a shift where people are starting to pay out of pocket for their own services, and they already have through private insurers. Even private hospitals, they have private hospitals now that it's through your private insurance or private pay.
That's
Yeah, it's a
sad.
different shift for them. Yeah. Mm-hmm.
It's depressing.
Mm-hmm.
Any other question? All right. Well, I don't see any other questions. So thank you so much, Julie. And I'm sure we'll have other opportunities. And I think there is a lot of really good opportunities for research. So that sounds great.
Great.
Thank you very much.
You.